Hello, welcome everyone to the PrecisCa Lung Cancer Tumor Board. I want to welcome all our panelists today. I am Ramaswamy Govindan, a medical oncologist at Washington University in St. Louis. I'm joined today by our experts. We'll start out with the introductions. Dr. Ginsberg.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Imaging and Vice Chair for Education at Memorial Sloan Kettering Cancer Center and Professor of Radiology at Weill Cornell Medical College.
I'm Larry Keston. I'm a radiation oncologist in the Detroit, Michigan area for Michigan Healthcare Professionals and Genesis Care USA Medical Director in Michigan.
I'm Tom Stinchcomb. I'm a medical oncologist who specializes in thoracic oncology at Duke University in Durham, North Carolina.
Hello, I'm Dr. Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of General Thoracic Surgery at Emory University Hospital in Atlanta, Georgia.
This is a 46-year-old woman with metastatic thymoma who presented with shortness of breath, unfortunately progressing to cardiopulmonary arrest, requiring resuscitation, stabilized and admitted to the ICU. Had a past history of diabetes, type 2 diabetes, gastroesophageal reflux disease, hypertension, no history of tobacco, alcohol, or drug use, worked as a nail technician, and as a history of lung cancer. And we have the scan from CT scan from December 2018. Dr. Ginsberg?
These images demonstrate this large anterior mediastinal mass, which measures up to 12.7 cm in largest diameter. In addition to that, we have a right lower lobe mass that's 4.2 centimeters and a small 0.8 centimeter left lower lobe nodule. And we don't have images of the pericardial effusion, but presumably it was drained by the time these images were obtained.
Right. And it was hemorrhagic, and that was a proximal cause of the cardiopulmonary arrest. Biopsy of the mediastinal mass showed thymic neoplasm favoring thymoma, the WHO type B2. With no evidence of metastatic disease on 4 or 7 by the endobronchial ultrasound, and was treated with the CAP chemotherapy regimen, cyclophosphamide, doxorubicin, and cisplatin in January of 2019, and had 3 cycles of therapy, and the CT scan revealed a response here, presumably, and Dr. Ginsberg.
So we see that these images demonstrate that indeed there was a response. This mass has now decreased from over 12 centimeters down to 9.3 in largest dimension. And there was still involvement of the pericardium and the superior vena cava, which again are not clearly demonstrated on these images. But as I mentioned, invasion of the SVC can occur if you lose the fat plane between it, and it becomes inseparable. The lung nodules in the lower lobes, you see that they have decreased. The one on the right was over 4 centimeters and is now barely perceptible. The left lower lobe nodule was very small to start with. So just a little bit of a decrease is still a decrease in the sub-centimeter nodule.
Thank you, Dr. Ginsberg. So she was evaluated by thoracic surgery, deemed not to be a candidate for surgery, and then was seen by radiation oncology. The plan was to treat with radiation treatment. And so the challenge for us is that what would we do? And I want to start off again with Dr. Ginsberg. Are these pulmonary nodules you think are metastatic, or this is a common problem we run into in these scans?
Right, it's difficult, but in general, a 4 centimeter mass is presumably a neoplastic lesion. Whether it's metastatic from the thymoma or another primary is hard to tell. The left lower lobe nodule has more of an appearance of a metastasis in the sense that it's a small, well-circumscribed lesion. Location also, a lower lobe, generally metastases are more likely to occur in lower lobes. But yes, it's difficult to ascertain that.
Okay. And Dr. Force, can you tell us your views on the surgical management of patients with thymoma?
Well, I mean, yes, I mean, we're obviously pretty aggressive with those tumors. They seem to be a little bit more indolent than other tumors we deal with, especially the thymic carcinomas. Although, you know, the B2 variant is more, you know, that would be an epithelial predominant, so maybe more getting more towards behaving like the carcinomas. But we tend to be very aggressive in those patients, you know, treating them pretty much similar to what we talked about before with neoadjuvant therapy if it looks like it's more than stage 2. So a stage 3 or even a stage 4 with isolated pleural metastasis will go in, resect, and remove the pleural metastasis in those patients in young and, you know, healthy, good operative candidates. So I would say we're fairly aggressive about treating those because you know, I think in you know, we can comment on this, but systemic therapy alone with radiation, it's hard to cure these patients, I think.
Yeah. So Dr. Stinchcomb, do you want to comment on the choice of systemic therapy here? And then we'll talk to Dr. Keston about radiation.
So like I think most of these tumors, there's a wide variety of chemotherapy regimens that are used for this. And I think this would be a standard treatment. I make sure I get an echocardiogram to make sure there's good cardiac function because of the doxorubicin-containing therapy. I think the other option out there is carboplatin and Metastatic chemotherapy is there. I generally use the CAP combination for good performance status patients without any contraindications. I think it's just a little bit more comfortable and a little bit more validated.
Would you have asked your surgical colleague to consider surgical resection and then pursue more aggressive, try to convince your radiation oncologist to add radiation? Of course, not with CAP, but come up with different regimen?
I probably would have done the same approach that this patient received, give the systemic therapy, make sure that we see a response, then do the sort of the consolidation radiation therapy. Many times these are discussed at tumor conference about surgical intervention at this point. And there's always a robust discussion, but most of the time we do not perform a surgical resection. And when someone has such a good response and seems to be doing well clinically.
And can you comment on the immune checkpoint inhibitor in this situation?
So immune checkpoint inhibitors are used. I've generally waited for the patient to progress and use them as a second line. A small single-arm trial with pembrolizumab showed a response rate of around 25%. The duration of response was around 22 months. So the people who responded got a lot of benefit. But the overall progression-free survival is around 4 to 5 months. I think the real concern is that there's a higher rate of immune-related adverse events, such as I think around 15% of patients had severe immune-related adverse events. And the big concern was about the rate of myocarditis. So that it is with some hesitancy that I discuss immune therapy with my patients with thymoma.
Thank you, Dr. Stinchcomb. Dr. Keston, do you want to comment on the radiation therapy options?
Thank you, Dr. Govindan. This is obviously a difficult situation for this patient having the pleural or possibly lung metastases. I think this case was handled completely reasonably, in my opinion, with chemotherapy up front. One can consider surgery and or radiation. We would typically do radiation treatment in this particular situation, just as was, I think, planned for this particular case. In cases that are maybe a little more common, where you have a rather large mediastinal mass, such as this one, without any evidence of metastases, then we would typically try chemotherapy first, potentially follow that with radiation treatment, and then surgery. Once, in this particular instance, the patient has some comorbidities, it sounds like, with diabetes and had a cardiopulmonary arrest, and of course has the metastases up front. We would typically manage this case with chemotherapy, followed by radiation treatment. And when one considers the metastases, I think we would have to see how the patient is doing following all of these treatments. And if you wanted to take a really aggressive approach, then you could potentially perform SBRT to those two metastases. Obviously, it's likely in this situation that the patient is going to have recurrences, but sometimes these patients, as you know, can live for many years and have a recurrence, and you treat it, and then a few years later, a recurrence, and you treat it. And so an aggressive approach is reasonable, generally speaking, in these thymoma cases.
I agree. I agree totally. And, we don't see any actionable mutation in these patients, so they are not typically candidates for targeted therapies. Although a small fraction of thymic carcinomas have this imatinib-sensitive c-KIT mutation that they respond well to imatinib. That's only in thymic carcinomas and thymoma. We never see them. And mostly they're all chemotherapy for most part in the setting of metastatic disease. And then, as Dr. Stinchko mentioned, immune checkpoint inhibitors. So to summarize our discussion, the optimal therapy for a patient like this with metastatic thymoma is unfortunately only chemotherapy. And the choice of chemotherapy regimens are the CAP regimen, the cyclophosphamide, doxorubicin, and cisplatin, or paclitaxel, carboplatin, and there have been responses with single-agent gemcitabine, pemetrexed, etc. Immune checkpoint inhibitor pembrolizumab can be used in the salvage setting, but with a lot of caution because there is higher rates of autoimmune reaction with this in this group than in other disease types, particularly the myocarditis, myositis, etc. And if patients have locally advanced disease, the tumor board would recommend that we consider these patients for chemotherapy followed by radiation and, if possible, surgical resection. So that's our summary of management of patient with thymoma. I want to thank you for the excellent discussion. Thank you.